Our last talk for today will be updates on postural puncture headache given by Dr. Reine Zbeidy, who's an associate professor of anesthesiology at the University of Miami, specialized in obstetric anesthesia. She earned her medical degree at the Faculty of Medical Science in the Lebanese University in 2004 and completed her residency in anesthesiology at the American University of Beirut. Dr. Zbeidy furthered her training with a residency at Jackson Memorial Hospital, University of Miami, followed by a fellowship in obstetric anesthesiology. Since 2018, she served as an obstetric anesthesia fellowship program director at the University of Miami, demonstrating her dedication to shaping future anesthesiologists. Dr. Zbeidy has an extensive research background with numerous publications and book chapters to her name. She also has extensive experience in resident education, contributing to curriculum development and advancing simulation technique to enhance clinical teaching. Dr. Zbeidy?
Hello, everyone. Today we'll talk about updates on postural puncture headache, a condition that has both immediate and long-term health issues. So beyond the discomfort it brings, postural puncture headache is linked to serious risks like subdural hematomas, cerebral venous sinus thrombosis, cranial nerve dysfunction, postpartum depression, chronic headaches, and backaches. So these complications underscore the need for early diagnosis, timely intervention, and a comprehensive follow-up. These are the learning objectives. I'll be talking about prevention, diagnosis, and evidence-based strategies in the treatment of postural puncture headache. I would highly recommend this paper published recently in JAMA Open, which is a multi-society consensus practice guideline on postural puncture headache. So postural puncture headache is a postural headache, which follows either intentional wet tap or unintentional following an epidural placement. The incidence varies widely depending on patient and procedure, ranging from less than 2% to 40%, and the presentation is usually a postural headache and sometimes with neck stiffness and subjective hearing loss. The headache usually goes away within 2 weeks, but it can be associated with severe neurological issues and complications, like I mentioned at the beginning, such as subdural hematoma or central venous sinus thrombosis. So, to begin, let's start with the definition. The International Headache Society defines postural puncture headache as being associated with low CSF pressure and an evidence of CSF leak. Interestingly, this latest definition omits the postural component that was included in the previous one. So, diagnosis of the postural puncture headache should be clinical, based on the presence of a postural headache that appears within 5 days after the neuraxial procedure. The current recommendation advises that all patients undergoing neuraxial procedure should be followed up. Inpatients should be monitored, and outpatients should be informed about the possible symptoms and instructed to report them to their healthcare provider if they experience any. Moving on to risk factors, patient-related risk factors, which are likely familiar to most of us. Younger age, female sex, and history of headache have all been associated with a higher risk of developing the headache. BMI did not show a consistent association with the risk of the headache. And interestingly, smoking have shown was associated with a lower risk of developing the headache, though it is a loose association. Now, pushing during labor significantly increases the risk of the postural puncture headache, especially if it is for longer duration. And then some studies have shown higher odds of developing the headache and a greater need for epidural blood patches in these cases. Increased cervical dilation, particularly beyond 7, has also been linked to a higher risk. Cesarean delivery may be protected by avoiding the pushing stage. However, some studies did show some conflicting results, likely due to differences in needle size, procedure type, and patient condition. For procedural risk factors, and based on this landmark systemic review published in The Lancet a few years ago, we now know that using non-cutting needles significantly reduces the risk of postural puncture headache and the need for an epidural blood patch. So specifically, the use of non-cutting needles was associated with a 60% reduction in the postural puncture headache risk. So we should be using non-cutting needles for all patient population, and if for any reason we are using cutting needles, we should be using the smallest gauge needle. So needle insertion method, midline versus paramedian, doesn't change the risk. Using a cutting needle with the bevel parallel to dural fiber may help reduce it. More attempts and less experienced operator increases the risk, the likelihood of developing the postural puncture headache. Different neuraxial techniques, spinal, epidural, and combined spinal epidural, have similar risks, and the insertion level, thoracic versus lumbar, doesn't make a difference. Now, to help prevent postural puncture headache after an accidental dural puncture, placing an intrathecal catheter can be a useful way to provide relief and anesthesia. However, using an IT catheter is not without risks, especially because accidentally giving an epidural dose through it can be linked to serious complication. We'll talk more about this in the next slide. As for using a prophylactic epidural blood patch to prevent the headache, it's generally not recommended as a routine measure. And then injecting a routine substance intrathecally or epidurally on a routine basis is also not advised. So instead, clinicians should assess each patient individually and then make judgment based on their specific situation. I do want to make one comment about IT catheters. So, research on using these catheters to prevent posterior puncture headache has shown mixed results. Apple's review of six studies found that using the catheter didn't reduce the headache rate or the need for an epidural blood patch. Heason's analysis found a slight reduction in epidural blood patch need, though there wasn't enough data to confirm this with confidence. And then Deng showed that intrathecal catheter did reduce both the headaches and the epidural blood patch requirement, though most of the studies reviewed were retrospective, which really limits reliability. So the overall data is inconsistent, partly due to difference in study design, patient type, and catheter use method. Some suggest leaving a catheter in place may help seal the dural hole by triggering an inflammatory response, but it's more likely that it simply reduces the CSF leak and symptoms. A recent article in Anesthesia published by the OAA provides valuable guidance on using these IT catheters. So, the key recommendations included closely monitoring these patients during labor and postpartum, much like epidural analgesia, clearly labeling the catheters, and they suggested using a consistent concentration of local anesthetic and fentanyl throughout labor to minimize mix-up. For C-section, they recommended using small doses of hyperbaric bupivacaine, 3 to 5 milligrams, administered in a fully monitored operating room environment. Additionally, the primary clinician should handle the catheter, and that catheter should be promptly removed following the surgery. Prophylactic epidural blood patch have been studied for prevention of the headache in patients with unintentional wet tap. And then they did show mixed results. Some studies found that prophylactically doing a blood patch significantly reduced the headache risk, while others showed no difference in incidence, but reported a reduction in headache severity and duration. Limitation included lack of blinding and short follow-up times. Overall, prophylactically doing a blood patch appears to reduce the posterior puncture headache and risk and severity, but more standardized studies is needed for conclusive recommendation. Moving on to management, for conservative measures for managing the post-dural puncture headache, bed rest is not routinely recommended, but it may offer some symptomatic relief. Oral hydration is definitely encouraged, and IV fluid is reserved for cases when oral intake is not possible. Multimodal analgesia includes acetaminophen and NSAIDs should be provided to all patients, with short-term opioid being acceptable for those not responding to other treatment. However, long-term opioid use is discouraged. Caffeine is found to be fairly effective, particularly within the first 24 hours after a postural puncture headache. The dose should be carefully managed, not exceeding 900 milligrams. For breastfeeding patients, the dose should be limited to 300 milligrams, and all sources of caffeine intake should be considered. Other medications such as theophylline, sumatriptan, and neostigmine are not recommended for routine use in managing postural puncture headache. When it comes to procedural interventions for treatment of the headache, quite a few options have been explored, ranging from the greater occipital nerve block, sphenopalatine ganglion block, acupuncture, epidural and spinal morphine, and obviously the epidural blood patch. Occipital nerve block can help relieve the pain by blocking sensory receptors at the back of the scalp. They have been shown to reduce the pain within the first 24 hours, but 25% of patients still requires a blood patch because of recurrence. So while it can be used for recurrence, it's common and then their overall efficacy is still uncertain. Now, for more complex interventions like sphenopalatine ganglion block, initially used for headache relief in 1908, there's been a recent interest in using them for posterior puncture headache. They may work by reducing parasympathetic activity, potentially leading to cerebral vasoconstriction. However, evidence on their effectiveness is mixed. Some observational studies suggest benefit. A meta analysis and a randomized trial found no difference in improvement over placebo. There's also a lot of variation in how it is done, making it difficult to draw a conclusion. Overall, the evidence doesn't support the routine use of the SPGB blocks, and more robust studies are needed to clarify their role. Epidural saline have some temporary benefit by increasing the pressure in the epidural space and decreasing the leakage, but usually the headache returns within 6 hours, and the vast majority of patients have the recurrence in the first 24 hours. Other substances like dextran, gelatin, and hydroxyethyl starch have been used in the epidural space, but the data is limited to case report or small case series, so their routine use is not recommended. Fibrin glue is associated with risk of anaphylaxis and aseptic meningitis, so its routine use is not recommended also. It's sometimes used when the epidural blood patch is contraindicated or did not lead to pain relief. Now, the epidural blood patch should be considered when the symptoms impact the daily functioning and the conservative management did not work. Though it is generally safe, it does carry some risks, particularly for patients with coagulation dysfunction or infections. So, these risks and potential benefits should always be thoroughly discussed with the patient during the consent process. Clinicians should follow appropriate guidelines regarding neuraxil injection in patients on antithrombotics or with low platelet count. The risk of epidural hematoma is low in obstetric patients when the platelet count is above 70,000, provided there's no defect in platelet function or other abnormality of coagulation. Now, we have to always be careful when doing a blood patch in febrile patient or patient presenting with systemic signs of infection. It might be prudent to defer the procedure if there is a risk of apathy. The epidural blood patch should be considered as a therapeutic option. Lots of randomized controlled trials have shown that the epidural blood patch have a higher recovery rate compared to conservative therapies. The success rate ranges from 33 to 91%, and a repeat blood patch could be required if symptoms recur. And especially if the timing of the epidural is important, as earlier intervention within 24 to 48 hours often showing better results. And sometimes delayed treatment may increase the risk of complication. The ideal intervertebral space for the epidural blood patch is typically at or below the site of the dural puncture. The optimal epidural blood patch volume is unknown and likely varies depending on the patient's factors such as size, age, degree of spondylotic changes, and the size of the dural hole. The most recommended volumes are between 15 and 20 ml. Injecting more than 30 ml does not appear to increase the success of the epidural blood patch. Strict aseptic techniques should be observed in both collection and injection of the autologous blood. And the optimal time for mobilization following an epidural blood patch is unknown, but patients are often advised to avoid the twisting, heavy lifting, and straining for 1 to 2 weeks following an epidural blood patch to avoid disruption of the blood clot and the leading to recurrence of the headache. And remember, an epidural blood patch is still an iatrogenic epidural hematoma. To keep in mind the patient's symptoms, and as you're injecting the blood in small amounts, any signs of increased pressure and pain should alert you to stop the injection. So, inadvertent dural puncture and posterior puncture headache are linked to chronic headaches, backaches, depression, cranial nerve palsies, subdural hematoma, and cerebral venous sinus thrombosis. There's insufficient evidence to confirm if an epidural blood patch effectively mitigates these complications. But there are key recommendations pertaining to patient education and follow up that patients should be informed about possible complication before discharge with clear follow up arrangement and contact detail for healthcare provider. The clinician responsible for the dural puncture should communicate the risk and management to the primary care team and relevant specialists. And then follow up should continue until symptoms, especially headache, resolve, and the primary care can take over after discharge. Urgent neuroimaging and referral to appropriate specialists should be done for any patient with worsening symptoms despite the epidural blood patch, or whenever they have new focal neurological symptoms or a change in the nature of headache. A change in headache from orthostatic to non-orthostatic can signal complications such as subdural hematoma, cerebral venous sinus thrombosis, or posterior reversible encephalopathy syndrome. A new neurological deficit, or visual disturbance, or seizure should also prompt you to go ahead with neuroimaging. And also, a delayed headache onset beyond the 5 days can suggest alternative diagnosis and should also prompt you to go ahead with the neuroimaging. The MRI is the most common neuroimaging modality. And this final slide is taken from the consensus practice guideline on postural puncture headache. It summarizes key recommendations with high and moderate levels of certainty for managing the postural puncture headache. I highly recommend going over this paper since it does provide structured guidelines for management of the problem. Thank you.
Any questions? Yes, Dr. Bashawati.
Question pour Dr. Benamou. Je veux savoir s'il y a toujours un rôle pour le facteur 7 activé ou le concentré de facteurs plaquettaires dans la prise en charge de l'hémorragie du postpartum et s'il y a toujours une indication à quel moment l'administrer.
Alors, est-ce que vous m'entendez bien?
Oui.
Oui, c'est bon, le son, c'est bon pour vous?
Oui, oui.
D'accord, très bien, merci beaucoup. Alors, il y a plusieurs questions. La première qui est la plus difficile, peut-être, hein, c'est celle du facteur 7 activé. Il y a actuellement dans le domaine de l'obstétrique une seule étude randomisée. Il faut que je réponde peut-être en anglais, non, c'est peut-être mieux, non, puisqu'il y a des collègues qui parlent anglais là. Donc, je vais essayer en anglais du coup. So I start again in English for Cynthia and Reine. So good. There's only one published study in which the human factor Novo 7 was used for obstetric hemorrhage, which was a French study in which they showed that it was useful to use this drug in obstetric hemorrhage. And the originality of this study was the fact that the drug was used rather early in the process of the obstetric hemorrhage. By contrast, in all previous studies, which are already old, the human recombinant factor 7 was used rather late in the process of obstetric hemorrhage because in most studies which were performed in non-obstetric settings, it was shown that the efficacy of this drug was not so magic. And in fact, it was rather used very late in the process when the situation was very severe and when the patient was rather already dying, and immediately before performing hysterectomy. So this study was interesting because the drug was used much earlier in the algorithm of treating PPH, and the study was positive. But in fact, the study was very small. There was a very low number of patients included in each group, although it was randomized, so it was a good point. But the number of patients was low, and there has been much debate all around the world about using this study as sufficient, as enough information to modify the protocols. So in many countries and in many units, Novo 7 is still used very late in the setting of obstetric PPH, but it is possible to use that much earlier because of this study. What is generally accepted is that it is not useful to use the drug before using the intrauterine tamponade balloon, for example. Not so earlier, but when the balloon has faded, then it might be useful to use a Novo 7 at that time, probably before performing either surgical uterine artery ligation or hysterectomy, for example, or embolization, for example. So probably it is possible to use the drug earlier than before. That's the most maybe useful information I can give today, given the low level of information that we have. The second question was about the use of platelet concentrate. I'm not sure to understand the question exactly. Could you repeat it, please?
The second question was about when is the right time to use it, but I guess you already have answered that.
Okay, very good. Thank you very much.
Can I add one more comment? And maybe you already said this, Dr. Benamo, but factor VII does not work unless you have platelets and fibrinogen and you're not acidotic. And so this may be an explanation for why it doesn't work if we give it very late, because we're giving it late and we already have severe thrombocytopenia, usually severe acidosis and hypofibrinogenemia, and it won't work in that circumstance. So you have to give it either with the other agents or early.
Okay.
Yes, Dr. Awad.
So this is Dr. Awad from the American University of Beirut. I'd like first to thank all four lecturers for their excellent interventions. And I have three questions for each one of you. I mean, Dr. Benamou, Dr. Wong, and Dr. Zbeidy. So the first one for Dr. Benamou, you did not mention anything about the B-Lynch sutures. Is it something that is used in France? And because we use them frequently in Lebanon.
Yes,
as compared to the effect of the Bakri balloon.
Yes, you are absolutely right, but I mentioned at the start of my talk that I couldn't discuss about everything because it is too much for a single talk of, let's say, 20 or 25 minutes. So I prefer to choose some points that I believe are interesting or new for the moment. So you're right, the B-Lynch technique is useful. It is sometimes used in severe cases. I cannot say very much more about that because there are, of course, no randomized trial using these type of techniques. So it is used as many of these surgical techniques for, let's say, rescue situation. So it is believed to be efficient, to be effective. There are some reports describing its effectiveness, but I can't tell you more about the value of the technique because it is not well demonstrated by, let's say, scientific evidence.
Thank you. And for Dr. Wong, what about the DPE? It seems to us from after listening to you that the only indication is an anticipation of a C-section.
So I think maybe if you work in a teaching institution, for example, and you're supervising residents, it's very helpful to have the confirmation that the tip of the epidural needle is in the right space. There's probably a higher failure rate of epidural analgesia in an academic teaching institution. So that may be an indication for doing a DPE technique. And again, I think if you're particularly concerned about not using a CSE technique. So let's say you're worried about fetal bradycardia, but you're also worried that your epidural technique is going to be too slow and you're not going to get a sacral block. There might be an argument for using a DPE technique, although again, the evidence is not very good right now. And there are studies that say it's better than an epidural technique, and there are studies that show no difference. So at this point, I think it's fairly hard to say that there is a definitive indication for the DPE technique. You are correct with your question.
Thank you. And one last question for Reine. What is your typical time interval before you propose a blood patch for your patients with postdural puncture headache?
So usually we wait after 24 hours. So the first 24 hours we try conservative management. I usually do OB. So we tend to do it within 24 to 48 hours. So we start with fluid hydration, oral hydration. We do give caffeine, and we have them on a regimen of ibuprofen and Tylenol, and then and then sometimes very rarely opioid. And then I would say 48 hours after, if they still having symptoms or there's no improvement in symptoms or deterioration, we go ahead with the blood patch.
Thank you.
Any more? Dr. Shalhoub.
Bonsoir, Bonsoir, j'ai une question à M. Benamou. Merci pour cette présentation qui est très claire. Et, vous avez commencé par parler du rôle du fer durant la grossesse. Est-ce que le fer injectable, vous le proposez durant toute la grossesse, une fois, deux fois, ou bien seulement le dernier trimestre?
D'abord, j'ai reconnu la voix de Viviane. Bonjour Viviane.
Bonjour, M. Benamou.
Bonjour. Alors, oui, on le propose maintenant, disons, assez fréquemment. Et, ah oui, en anglais, pardon, excusez-moi. The use of intravenous iron is more and more frequent in our practice. Because as I mentioned, the role of anemia during pregnancy is really very important, and prevention is very important. And it is more and more, let's say, important to treat or to prevent, to treat anemia when it occurs. So, and we know that oral iron is not very effective. There are many patients who do not support, who have gastrointestinal symptoms with oral iron, so it's very difficult to use. So in most situations, we try to use one dose. Generally, the mean dose is about 1,000 milligrams, 1 gram. And sometimes it's necessary to use a second dose, depending on the timing of the detection of anemia and the intensity of anemia. In many cases, one dose is enough, but in other situations, it's necessary to use 2 doses. Generally, we have a time lag between 2 injections of 1 or 2 weeks. And also it depends on the timing as compared to the timing of delivery, if you are very early or late in pregnancy. It's not recommended during the first trimester, but in second trimester, it is also rarely used because we still have time to try if oral iron will be efficacious, will be effective. And so it is most of the time used, let's say, rather late in pregnancy, when time is when delivery is coming soon.
Merci.
Any more questions? Yes, Dr. Jbara.
Oui, bonsoir, merci beaucoup pour les questions. J'ai une question pour Madame Drouat et je sais que vous préférez répondre en français. C'est juste pour les filtres. Est-ce que vous utilisez les 40 microns ou les 170 microns? Et est-ce que vous gardez les filtres antileucocytaires pour les cas de carcinologie?
Alors, pour les filtres à des leucocytés, comme ça, j'en parle plus après, on les garde que pour effectivement, les situations carcinologiques. Parce que même dans les cas d'infection, ils n'ont pas démontré leur efficacité. Pour ce qui est des filtres, pour l'instant, nous utilisons, et depuis le début, des filtres à 40 microns. Récemment, alors dans les cell savers, il y a différents types de cell savers. On utilise nous un cell saver continu de Fresenius et ils viennent de sortir un réservoir avec un filtre intégré de 40 microns au lieu du filtre de 120 microns qui existait. Ce qui va nous permettre de ne plus utiliser de filtre supplémentaire entre notre poche à retransfuser et notre patient.
J'ai encore une question. Qu'est-ce que vous pensez des Cell Saver ICEP qui récupèrent les plaquettes?
J'ai pas du tout cette expérience. Ce que je sais, c'est que quand on analyse la poche à retransfuser, il y a un petit peu de plaquettes. Et on voit que dans notre pratique, finalement, on transfuse peu de plaquettes, même quand on est obligé de transfuser, enfin, d'auto-transfuser notre patient avec des volumes impressionnants d'1,5 litre, d'1,2 litre retransfusés, donc des saignements de plus de 4 litres. On a peu besoin de plaquettes par rapport à si on utilisait une transfusion homologue. Et j'ai pas l'expérience des cell-savers qui récupèrent les plaquettes pour l'instant.
Dr. Roumoulian.
Yes. My question is for Dr. Zbeidy. I would like to see concerning the blood patch when there is an unintentional dural puncture. Would you preconize to redo the blood patch under echo or to do a paramedian approach? And the second question, as a matter of fact, two of them. Do you use PRP for instead of the blood? Is it something that might be something new in this domain?
So for your first question, so using, what was the first part before the using paramedian versus midline?
If it is an unintentional dural puncture, so maybe the midline was loose, and what we might do another breach, another puncture if we use the blood patch.
All right. So no, we typically don't do that. We usually try to go with the midline approach, either same level or one level below, because usually the spread is 2/3 up, 1/3 down. Sometimes if we think it's a difficult placement, we use the ultrasound to be able to delineate midline and then count the levels and to be able to see it more clearly. We do not do midlines because we're not familiar with the technique and it might be associated with more risks. And then what was the second question? The PRP, no, I'm not familiar with it. We don't do it.
Okay, thank you. And une question concernant le cell saver. Quand vous dites que vous prenez les compresses imbibées de sang et que vous les mettez dans du sérum physiologique et que vous allez les réutiliser encore une fois, y a-t-il un risque d'hémolyse dans ce cas-là?
Alors, nos compresses, donc effectivement, on demande à notre chirurgien de ne pas jeter les compresses quand on voit qu'il commence à mettre beaucoup de sang dans des compresses. Du coup, tout est lavé et avec des gants stériles, on les essore. Effectivement, il y a un risque d'hémolyse qui existe, on n'est pas tout à fait bon, donc on les lave en douceur. Et le cell saver, au moment où la centrifugation se fait, va éliminer toute cette partie hémolisée. Donc, ça peut diminuer un petit peu le rendement, mais en tout cas, c'est beaucoup plus intéressant que d'avoir la quasi-totalité du saignement parfois qui se retrouve dans les compresses et qui est jeté. Donc, c'est peut-être pas aussi doux que le traitement du cell saver, mais c'est très efficace. Est-ce que j'ai répondu à votre question?
Oui, merci.
Okay, I still have one online question for Dr. Wang. For DPE compared to CSE, do you think the DPE is better to assess immediately the good position of our catheter compared to CSE and with better onset compared to epidural? And if our epidural is not working properly after hours of infusion, if you want to change it and patient is in severe pain, do you think DPE is better to avoid high spinal if we want to use CSE and we want earlier onset?
Yes, so those are both very good questions. So I'll address the last one first, which is that I don't think there's a risk of high spinal in this situation because we are using such low amount of bupivacaine. So we only use a couple of milligrams, 1 to 2 milligrams. And so it doesn't really matter what volume is in the epidural space at that point. It's never going to push it up high enough so that there is a dangerously high level. So I don't think it is a contraindication to doing a CSE. The question about whether or not the epidural catheter is going to work. So there have been, or you can tell whether the epidural catheter is going to work. So this has been a concern with CSE. that when you do the CSE technique and thread the epidural catheter, you're not using the epidural catheter for analgesia for the first hour or so, and so you cannot tell if it's not functioning. I did not put that up there on my list of advantages and disadvantages because there have been several large retrospective studies which show that the catheter does not, the timing of identification of catheter failure does not make a difference if you do an epidural versus a CSE technique. And in fact, you get better success with the CSE technique for the reasons that we probably described. The DPE technique has not been done long enough so that there are any large retrospective studies comparing the two in terms of catheter failure or not. Makes sense to me that it would have a low catheter failure rate compared to an epidural, again, because you're verifying that your epidural needle tip is in relatively the same spot, but that hasn't been demonstrated. So I no longer consider whether or not the epidural catheter can't be tested right away. I prefer to use either a CSE or, again, if you didn't want to use a CSE technique, a DPE technique, just to make sure that the catheter is likely, your epidural needle and the catheter are in the right spot.
Thank you. And they're asking also if you use separate needles or needle through needle.
We always do needle through needle.
Okay.
I have never done a separate technique.
And how much fentanyl in case of CSE, in case of cardiomyopathy?
So somewhere between 15 and 25 micrograms of fentanyl. If I was giving fentanyl by itself, I would give 25 micrograms.
Thank you. Dr. Barakat.
Yes, thank you very much for this nice talk this afternoon. And I would like to have short questions for each one of you. I will start with Dr. Benamou, first of all. Dr. Benamou, you know, you're going to face a bit some strange questions because I'm not an anesthesiologist or a pain professional. I'm a gynecologist, obstetrician, and I'm going to ask the questions I'm asking usually to all my colleagues. Every day we're working together. So, you know, for the postpartum hemorrhage, which is, you know, a headache for all the team, including us and you and all the working team at the hospitals. I think that, you know, whatever the mechanical reason is for the bleeding, it doesn't cause any problem for skilled or experienced surgeon. However, our fear is always coagulopathies and Dick syndrome. So my first question for you is, does it help really for a patient at risk, let's say for those having placenta increta or percreta or so on, to start our operation together with fresh frozen plasma, for example? We cannot hear you.
Sorry, now I put the sound on. If I understand correctly, your question is that you would suggest to use FFP, you know, fresh frozen plasma in prevention before hemorrhage?
Yes.
Am I right?
Yes. Does it help?
Okay. As far as I know, there is no situation in which prevention, the use of FFP is useful for prevention. It is not recommended in general.
No, it's not prevention. I said
I'm sorry.
early during bleeding, not for prevention. Yani as soon as we have a bleeding and we decide to intervene, is it really useful to start infusing immediately or we have to wait?
I think you have to wait because generally speaking, there are protocols which are very well established in which we start by using red blood cells, then followed by fresh frozen plasma and platelets. So it is not recommended, as far as I know, that it is useful to start by using FFP, except maybe in situations in which there is a pre-operative situation, for example, maybe in cirrhosis, for example, or in patients who have an abnormal coagulation before surgery, but in let's say normal patient with normal coagulation before surgery, even if there is a very high risk of transfusion, it is not useful. It is not recommended to start by giving fresh frozen plasma.
Okay, thank you. And Dr. Wong, I would like to ask you two small questions. The first one, what is the rate of failure of analgesia for the normal Zbeidy, your department?
Well, again, it's good that you said my department because it's very dependent on institution and whether it's an academic institution or a practice where they're experienced anesthesiologist. It's probably somewhere between 5 and 10%.
Excuse me, I couldn't get it. I didn't get that.
Between 5 and 10%.
Between 5 and 10%. What do you think the reasons of failure are?
This is for, we're talking about neuraxial labor analgesia.
Yes.
So not for a C-section, right? So I think there are several reasons. Number one, the epidural catheter is not in the right place to start with. Number two, it's off to one side, which is fairly frequent. Remember that we can't see what we're aiming for. And, you know, pregnant women are often rotated. Their pelvis is uneven and they're often rotated. So even though we think we're in the midline, we're not in the midline when we actually reach the epidural space. I think there is a fairly significant number of patients who we struggle with this sacral sparing technique. In other words, they have good analgesia early in labor, and then during the active phase and the second phase of labor, the analgesia fails. There are some tricks to trying to fix this, including increasing the concentration of local anesthetic and opioid that we use, adding another drug like clonidine, which has a different mechanism of action, and alpha-2 action often helps. And that's beneficial because it doesn't contribute to motor block, which we're trying to avoid. Sometimes the catheter comes out, it moves right after many hours of labor. The patient is moving around in bed. So this is another reason for failure.
All right. And how many times would you give a bolus instead in case of failure or in pain?
Well, we rather have a technique where we don't have to give a bolus, right? And so there are different ways to maintain labor analgesia. The most, I would say the most common techniques in use now are PCEA, so patient-controlled epidural analgesia. There's some discussion about whether or not that should be administered with a continuous background infusion or not. There are advantages and disadvantages to both. In general, it's better to give the drug as a bolus because it spreads better in both directions. When you give the drug as a continuous infusion and it just drips slowly into the lumbar epidural space, you anesthetize the legs, but you don't anesthetize the uterus and you don't anesthetize the sacrum. So giving it as a bolus is better. And the patient can give themselves a bolus, right, with the patient controlled bolus. Or a newer technique is called programmed intermittent epidural bolus, where the infusion pump is actually programmed to give a bolus at a regular interval, usually every 40 or 45 minutes. It gives a large bolus to maintain analgesia.
Thank you very much. Docteur Zouar, j'ai une petite question pour vous. Ça prend combien de temps pour préparer le sang en post-op ou bien durant l'intervention?
Combien de temps pour?
Préparer le sang pour la réinfusion.
C'est extrêmement rapide. La première partie, c'est de le récupérer et dès qu'on a suffisamment de sang, on va le traiter. Si vous êtes en procédure d'urgence, en 3 minutes, vous avez un culot sanguin.
Donc, après la récupération de sang, ça prend 3 minutes pour préparer
Extrêmement rapide.
Bon. Et pour Dr. Zbeidy, for Dr. Zbeidy, I have only one question. So you said you wait 24 to 48 hours before passing into the blood patch. So when if someone's wait for 4 to 5 days, is it something good or something bad if you wait more than 48 hours? Yani, is there any timeline? Is there any timeline to do the blood patch, or you can wait even if you wait more than 48 hours?
So the recommendation is to do the blood patch 24 to 48 hours after the dural puncture. Now, if the patient decides to not do it and then come back for it later on, you still can do it. But the longer you wait, the more prone to complication you are. Now, and sometimes for the OB patients, there is we tend to do it earlier because some of them are like standing up or taking care of their baby, so their symptoms might be severe. Also, it depends on the severity of the symptoms. Some patients present with severe symptoms immediately after the dural puncture, so you might have to do it earlier than the 24 to 48 hours. So, but usually the recommendation is 24 to 48 hours after.
So basically, if anesthesiologist convinced the patient to wait for more times, 4 to 5 days, this is not right, this is wrong.
No, that's not the recommendation.
Okay, thank you. Thank you very much.